So the next speaker, I think I've already introduced Dr. Sujata. She is the director and head of pediatric ophthalmology and strabismus at Shankaranethralaya, Kolkata. It's always wonderful to hear her. I think she teaches a lot. I've also learned so many things from her when in my younger days. They were my mentors, you can say, Dr. Sumita and Dr. Sujata. I used to learn so much from them in strabismus whenever I used to hear their lectures.
Thank you, Dr. Suma, and thank you for inviting me to this very relevant and very apt instruction course in this day and age. So I will be dealing with the higher visual function deficit in CVI and its correlation with MRI. Now, MRI is something which all of us are not very familiar with, and let me see how to make it a little easy for all of you. In the next few minutes, I will be telling you when to do MRI, what to look for in MRI, the common pathologies that can be seen, and what children you can expect what in MRI. So let me start with a little revision of what you have heard. We have OVI on one side and we have CVI. OVI is ocular visual impairment, where you have damage to structures from the eye to the visual pathway till LGB. And usually the vision in the traditional sense, that is acuity, contrast, color, is affected in OVI. And we have on the other side CVI, or the cerebral visual impairment, which results from damage to retrogeniculate pathway. And here the visual acuity could be perfectly normal, but the patient may have abnormal visually guided behaviors or higher vision function deficit. So as Dr. Asmita has pointed out, we have two cerebral networks which deal with the higher visual processing. One is the dorsal network, which deals with the where. It is the occipito-parietal network, and it deals with the spatial processing. And we have the ventral network, which is the occipito-temporal network, which is the what processing, that is the objects and its shape and size. Now again, this is a revision. We have seen lots of causes of CVI, but the most common causes are hypoxic ischemic insult, neonatal hypoglycemia, and seizures. Now let me give us brief, I know Dr. Sovita has covered it in large details. Briefly, what are abnormal visually guided behavior or higher visual function deficit? These can be visual field preference, latency, attraction towards movements, or absence of visually guided reach, light gazing, and we might have color preference like a red preference, and sometimes difficulty in a complex visual scene, that is called simultagnosia. So now coming to the higher visual function deficit depends on the timing of insult, location of damage, and degree of insult, and all three of which can be beautifully studied in MRI. So whom should we order MRI? Any child, like you saw, with history of predisposing risk factors, or a child who has a stormy postnatal course with a poor Apgar score, or a normal child with a normal perinatal history but showing neuroregression. These are the candidates where you will order MRI. What MRI sequence will you order? It is a MRI brain without contrast is good enough. Conventional T1, T2 weighted images diagnostically are most useful from second week of insult onwards, and they show abnormal hyperintense signal on both T1 and T2 weighted images. Diffusion weighted images diagnostically are most useful in the very acute phase within the first week of the insult, and they show diffusion restriction. So which areas to focus? Like we discussed, it is the retrogeniculate pathway which causes higher visual function deficit. So you should focus on the retrogeniculate pathway, which includes optic radiation, the parietal cortex, the trigones of the lateral ventricle, the occipital cortex, the thalamus, and the inferotemporal cortex. Some of the common findings which you can expect in MRI includes, the commonest finding is periventricular leukomalacia. They can also have cerebral dysgenesis, parieto-occipital and parasagittal infarction. occipital lobe infarction, and diffuse cerebral atrophy. Let me illustrate with one of our patient who came to us at age 7 months with the parents complaining the child is not fixing or following toys or light and has wandering eye movements with absence of neck holding. He was born full term, but the child has a history of prolonged episodes of convulsion immediately post birth. His anterior and posterior segment was within normal limits, and his MRI showed cystic lesions in bilateral parieto-occipital cortex, cystic changes in the trigones and occipital horn of the lateral ventricle, and hyperintense signal in the occipital lobe. This child underwent early intervention and vision stimulation, and currently he can track objects, reach out objects, hold objects, and walk without support. So as Dr. Suma mentioned, early intervention can tremendously improve these children's performance. So how does time of injury influence MRI finding? In preterm neonatal brain, the injury is mainly periventricular because the blood supply is from periphery to center. It's a border zone, and this is the area which gets affected if there is a compromise in the blood supply. However, in injury to postnatal or term neonatal brain, the injury is more peripheral because of again the blood supply here. Now it's a watershed zone with the periphery, with the central blood vessel and the peripheral blood vessel merging here, and injury in term infants involves parasagittal watershed cortex and subcortical white matter. So any insult during the first trimester will cause tissue liquefaction, necrosis and resorption, but they will heal without gliosis. So cerebral dysgenesis is seen on MRI in an insult which is occurring in the first trimester. You can get lissencephaly where there is smooth brain and absence of gyri, or you can get polymicrogyria where there is increased number and reduced size of gyri, or you can have schizencephaly where there are abnormal clefts in the cerebral hemispheres. Now, insult in the later part, that is in the second and third trimester or in preterm children, causes repair with gliosis of the subcortical white matter, and they lead to classical lesion of the periventricular area or periventricular leukomalacia. So, periventricular white matter is the most commonly affected in preterm babies, and you can find hyperintense signal in the periventricular white matter with dilated and irregular ventricles. You can also have cortical lesions which can affect the optic radiation, especially the superior part of the optic radiation, which can have inferior visual field defects, which can lead to the difficulty in climbing up and down stairs, as you have seen. The corticospinal tracts also lie very close to this area, and the children can get cerebral palsy if this is also affected. So periventricular leukomalacia follows a very characteristic pattern of evolution. They undergo necrosis, cavitations, cyst formation, and then the cyst collapse and results in gliosis. So PVL lesions seen on MRI could be cystic lesions, could be dilated ventricles with irregular wavy outlines, could be reduced volume of periventricular white matter, or they could have increased signal intensity, thinning of corpus callosum, and lesions of the thalamus. In term infants, you have injury or insult to the watershed zone between the MCA and the PCA territory, and death of cells can lead to ischemia in the watershed area, leading to reduced white matter volume, or they can have infarcts in the bilateral occipital lobe, which can affect color and contrast vision and their field of vision. They can also have infarcts in the parietal lobe, which we have already seen affects the Weyr stream, or they can have a diffuse cerebral atrophy. So let us come to what the literature is saying. We have a little old literature by Ugeti et al., who reviewed and compared MRI of 27 preterm children affected by CP and the degree of visual acuity deficit. 63% of their patients had CVI. The PVL changes in the path of the optic radiation and calcarine cortex were led to most severe in cases. So he concluded that MRI findings should not merely confirm the diagnosis, but you should give specific consideration to the geniculocalcarine tract and the pyramidal pathways. Sioni et al. Also reported MRI scans correlating with CVI in patients with neonatal encephalopathy, and they found that PVL damage, PVL changes with damage to the optic radiation spelled poor prognosis. We reviewed 20 children, the files of 20 children less than 10 years with diagnosis of CVI, and in our group we found 70% had more than one etiological risk factors, with birth asphyxia being the commonest. And we found that the dorsal stream involvement were more common in our group than the ventral stream, and it correlated well with the corresponding visual fields. Some of the newer advances include the high angular resolution diffusion imaging, the HARDI, which can image the functionality of the brain. And here you can see a distinct reduction in the structure in the geniculostriate projections, and it helps providing neuroanatomical basis for vision deficits in CVI. So to summarize, we need to be vigilant in history taking, we need to be meticulous in patient assessment, giving time, request for specific areas of MRI scan, correlate the scan with the vision function, with the visual function impairment, and guide the rehabilitation accordingly. Thank you.
Excellent presentation. I told you, she's a very good teacher. Excellent. I've learned, she explains things so beautifully, and this is what I've seen for how many years now, 20 years. I've watched her present, and always I have learned something from her presentation. She explained, I remember the adjustable suture of her presentation, Dr. Sumita, where she used to take the rope, separately a rope, and she used to show us how to tie the knot in that. So, in fact, that's how I had seen her presentation for the first time with how to do an adjustable, and she had presented it so well.
Thank you, Dr. Suma.
Yeah, excellent. So I think what we found also in our study was that hypoglycemia, and I think Haroli did a very nice study with us, and she found out that hypoglycemia and hypoxia were the main common factors for as etiology. And very nicely demonstrated all the MRIs. Like, we also want to know which, in which condition, where maximally the children are affected, because occipital lobe, yes, the vision is mainly the impairment, but we found out that if parieto-occipital lobe is affected, then it is really a problem, because the children also have CP along with that, and then your coordination becomes a problem, like eye-hand coordination, and then you are struggling because the child cannot write, and you are doing the exercises for the vision also, and the child has motor and issues, and also children with a lot of sensory issues. I think the agenesis of corpus callosum was another which I found that was not very good prognosis. The other periventricular leukomalacia, it depended on how much it was affected. Yeah, it was much we could manage. The other problem is when we have children with epilepsy. Like, when they have epilepsy, you have treated, and then they get an epileptic episode, and then they go back to what you have improved the child to. So these are a few of the children, like we found, like epilepsy especially, like was a real deterrent, and especially for treating it also further. Like if you have a squint, then it's a problem. Like they won't take up anesthesia, and that's the reason. So